Thank you, Indore Ophthalmic Society and Dr. Rohit Shetty for giving me this opportunity. I am going to talk on Wavelight Plus right now. So the first speaker, Dr. Palak, has made my work simpler so I can concentrate on the points which are more important. We straight away go to what is the difference between different technologies. So in Contura, as she has already explained, that we are studying 22,000 points on the corneal surface only, whereas in aberrometry, you can see the pointer. Okay, the first thing over there, in aberrometry, you are just measuring the aberrations of the entire eye. Okay, but what Wavelight Plus is doing is this plus this and something else. So what Wavelight Plus is doing, wavefront guided, that means aberrometry guided treatment, and topography guided treatment, that means Contura, and the geometry of the anterior chamber axial length, etc. Now, all these things, if you want to do together, you require a single device, and that is what they have done. The most important part of Wavelight Plus is that everything is available on the single device. Secondly, what Dr. Palak showed, that you have to choose and pick and choose which maps are to be chosen. All those things are done by Wavelight Plus. And the third thing, the calculations, like now the calculations of Contura have become very simple. We understood quite a lot, but like say about 6-7 years back, pre-COVID era, there was time when I have struggled for 20 minutes for calculation of a Contura patient. All those things are taken care of by the computer. I don't have to bother about them. With all these things, it creates a 3D eye model within the computer, and it adapts the model. Now again over here, the back part, you can see the last part, that means the posterior surface of the lens and vitreous, the aberrations from there, they are based on narrow eye model. Okay, narrow eye model is a, it started from Gulstrand, but it is much more realistic model, and nowadays for all the calculations, all the people like Warren Hill and everybody, they are using narrow eye model. So the last part is taken by the narrow eye model, and once you do that, then you have to do iteration and reiteration. That means it just goes to and fro, understand what type of customized treatment is very good for this patient for us to get good results. And that is why it is, you can say that it is truly customized treatment. And the last part, which is also a most important part, is that it compensates for the wound healing, corneal healing. Now, they have made it very clear in the literature that they are taking care of the epithelial wound healing, but whether they are taking care of the stromal healing or not, that is not clear. However, epithelium, as we have been already discussing, it plays a huge part in the post-operative result. Therefore, it is safe to say that we are taking care of the major part of our problem. And that's why, because it is covering all these things, Wavelight Plus results are truly better. The only thing perhaps remaining right now is the posterior part of the eye, whose measurements, I don't think they are going to matter so much. So as I already said, that all these three things are available on the single machine, and this is the wavefront examination. We do it in scotopic condition, and now over here you will see that there are ticks. The reading has been selected by the machine. I don't have to go and match with each and every machine reading. Similarly, axial length, and similarly topography, the Scheimpflug imaging. And this is the overview. And you also see the fringe pattern, that is the aberrometer. You see the fringe pattern, you see the lens array, and you see whether the image is also proper. So this gives us a really good understanding about how the things are. But even though we say that a lot of things are mechanized, okay, automated, you cannot take things for granted. You have to look into details. So when you click on this thing, this yellow or green tick, you get a pop-up window like this, which tells us details about that reading. Now this is a screen regarding the aberrometry, and you can see that there is only one yellow, and this says that spherical equivalent is only problem. Otherwise, all the scores, the reading is good. And then you can decide, in addition to what machine has done, whether to choose or delete this reading, exclude. This is about the topography. It tells us whether 100% data is acquired or not, or what is extrapolated, and so many details are there. These are very important. Same thing about actioning. Now, just to give an example, you can look at this screen. If you look at the lens array, there is a lead, there is an eyelash in between. Okay, this eyelash is there, and that's why, see, this patient's eyes not fully open, and this patient, if we do Wavelight Plus, we are definitely not going to get a good result. Similarly, second patient, you now look at the fringe pattern, the aberrometry. You will see that in 4 or 5 readings, the aberrometry changes quite a lot. Obviously, this patient has probably dryness, and that's why we are not going to get a good result. And therefore, even though a lot of things have been automated, it does not mean that we can take things for granted. There is certainly some amount of learning curve, but the results are, quite good, and like that's why you don't mind having the learning curve. Then this is the, you go to the workstation now, patient details, and choose InnoVise. Everybody using examiner Wavelight platform is aware of this. And then you go to the first page. Now on the first page, subjective refraction is written on top. Okay, this machine does not take into consideration at all. Machine is doing its own calculations. The best part of this is that it is giving us wavefront refraction at 2 levels. Over here, it is giving you wavefront refraction at 4 millimeter, and over here, it is giving you at 6.5 millimeters. So if there is too much of difference between the two, again, it's a red flag. Similarly, aberrometry, topography, and after that iris registration, and on the small window which is remaining over there, you see the anterior segment of the eye. That is the ACD and axial length also over there. You keep on choosing everything. Now this is what Palak has already shown, that you choose whichever the graph you like, whichever reading you like. You enter the topography, pachymetry, and now this is the final page where you do all the calculations. I will go into the details later on because I have an example to show. And this is a registration window. So here R comes here over here, which means that these things are good enough for registration. Without registration, there is no point in going ahead with Wavelight Plus treatment, because you will not be compensating for cyclotorsion. Now this is a live example. Okay, first thing I see is the axis, 175, 173, 180, quite matching. Refraction, quite okay. 4.96, 4.98, 4. I will come to this later on why. And the cylinder is slightly on the higher side. We'll come to this later on. You choose whichever graph you want. Similarly about topo. You enter pachymetry. Yeah, thank you. So you enter pachymetry, and now this is the place. This is the question we are worried about. Patient has a cylinder of 1.5, aberrometry showing a cylinder of 2.32. First thing I will go is on epithelial map. Okay, upper epithelium thicker, lower epithelium thinner by 3 microns. It is giving me a refractive error of 0.25. So in this case, epithelium was good. Now, but in this patient, posterior corneal astigmatism was 0.7. So from 1.5 already gone to 2.2. Then I will click here and I will see how much, okay, higher order aberrations is our contribution to the astigmatism. You can see that 7 and 3, so 4 micron difference, and the cylinder is being treated in this axis, whereas our cylinder is in this axis. So we will have to compensate for that. That means we will have to increase here. That is why this cylinder is more than the subjective cylinder. So therefore there is, like, the riddle is solved. If the difference, that means the unaccounted cylinder, that means the lenticular astigmatism was 0.5 or more, I would not have gone ahead with the treatment. Then I go to, okay, now there is an algorithm by which you reduce this by about 10%. And I was talking, with respect to 10% only. I was not talking with respect to that. But what is a good thing about this is that if the cylinder matches, we can blindly touch this cylinder, we can treat it as it is, whatever algorithm is there, and it works just very well. Patients are left with very minimal cylinder or no cylinder at all. And then this slide was shown, cyclorotation registration, very, very important. The most important thing is, as we keep on going with higher types of LASIK, is doing absolutely flawless LASIK. There is no place for microstriae, slight displacement of the flap, regular wetness of or dryness of the bed as we start the treatment, because these are all contributing to our problems, and therefore flawless LASIK is a must. Now we come to some studies. Arthur Cummings did this study. That means he had 3 different machines, okay, and they were entered into a computer and the calculations was done. And as compared to that, there is a single device, what we saw, the InnoVoice device. Okay, what they showed is that the results were equally good. Their post-operative data. So 82.5% of the patients were 20/16 or better. It's a very, very impressive figure. And only less than 4% of the patients had loss of vision. Okay? Loss of 1 line, loss of 2 lines, which is again a really good figure. This is something which I was surprised about, is that whatever their manifest refraction was and what the result was, and they were within plus 0.5 in very less number of cases. In reality, all of us, I am sure that very few of us are getting so much of surprise, refractive surprise after surgery. Patient satisfaction, very good. Now these are results at Wavikar Institute. It's a very, very interesting graph. This is the preoperative visual acuity, okay, and this is the postoperative percentage of patients. If you add this and this will become 100, and this, it will become 100. So I am talking about a group of patients who had pre-op vision of 6/9. In them, large number of patients, there was gain of 1 line. But as you go towards 6/9 to 6/6 to 6/5 to 6/4, the situation changes. For 6/4, okay, 95% of the patient had same visual acuity, 6/4. But 5% of the patient, that means one of my patients, he lost 1 line. So we have to be very careful when we are doing patients with 6/4. Basically, when the patient is 6/9 or 6/6, what it means is that there are a lot of aberrations, and because of that, he is not reading 6/6. And the moment we correct the aberrations, he will go there. And when the patient, we are doing 6/4, the surgery has to be very, very meticulous and fine level, and that is why there is a slight drop in 1 or 2%. Okay. Now, but visual acuity, as we know, is not a very good marker of quality of vision. It's just a quantity of vision. And if you see the quality of vision post, this is 1 month post, is quite good. The amount of aberration patient is having is really great, low. And we do not do 3 months, but corneal wound healing is supposed to be done for 3 months, but we don't do 3 month post-op, so I don't have that data. Again, very less amount of abrasions. There was one patient who, after 1 month of LASIK, Wavelight Plus, started getting drop in vision, and it was especially at night. And his epithelial map showed that there was epithelial thickening. See over here, hyperplasia, 4.58. Okay, and this annulus we get normally, but in this fellow probably it was little exaggerated, and we treated it. After 2 to 3 months, he became normal. So, summary: Wavelight Plus gives better results than previous custom LASIKs. Meticulous pre-op evaluation, planning, intra-op execution is essential for excellent results. And there is a learning curve, even though it is more user-friendly than compared to the previous technologies. Thank you.
Thank you so much, sir, for those wonderful pearls. Do we have any questions for Dr. Wavikar, sir?
I think world over, one interesting thing is exactly what you showed, is that the gain of lines is more in this because it is looking at remodeling every layer of your cornea, maybe because of that. So I think that is what is seen in your studies and also everywhere else.
Yes.
Sir, one question. Where you will not do this in-voice procedure?
Very good question. See, initially my rejection rate was around 50%. And that is the time I thought that I have done a financial harakiri. But now the results, the inclusion criteria have improved. For example, if the pupil, scotopy pupil is 4.5 or less, it does not allow. Now we have circumvented it, that we do axial length and topo with undilated pupil, and we do abrometry with a dilated pupil.
Sir?
Because for registration it is using topography image, so small pupil. Like that we are doing, and therefore the incidences are of, we doing, indications are increasing. 2 or 3 major indications, contraindications. Number 1 is that we are not able to explain the cylinder. Number 2 is excessive dryness, epithelial irregularities. And I think, see, if the patient has excessive accommodation, that means sometimes the difference between spherical equivalent of subjective and this is something like 2.5, 3. And whatever we do, the patient does not relax. Again, I am very wary of doing such a case.
Sir, what about lenticular aberrations?
Lenticular aberrations have been taken care of.
So,
what is
my question is that when you treat the lenticular aberrations on the corneal level, because we are treating at the corneal level.
Yes.
So lenticular aberrations we are taking care over there, and suppose that patient goes into a cataract surgery later on.
Yeah.
So now we are putting an implant over there. So definitely the aberrations which were corrected will be opposite side aberrations.
Absolutely.
And maybe the IOL may have different aberrations.
Correct.
So
But
what will be the outcome in those patients?
See, this answer is actually quite simple. See, we are doing LASIK at the age of 25, and we are doing cataract at the age of say 55, and the abrasion profile of these 2 patients is totally different. So it does not matter.
And one thing which is very useful in this type of procedures and also silk and these procedures is you are maintaining the asphericity of the cornea in such a good level that even if you're treating -6 with a wavefront optimized treatment versus a -6 with this, there is at least 28 to 35% of preserving your own spherical aberration in your cornea and preserving your Q value compared to a regular thing. So what it translates it is the same person after 25 years gets cataract surgery. Whatever type of lenses is there at that point of time, including the best multifocal lenses, that means you're preserving the asphericity and shape to a stage as it was before the surgery. So you have a good chance to give him the exact multifocality in your cornea as you would give a healthy person. So today, one of the challenges why you are not putting multifocal lenses is 25 years back, we were doing laser with 3-4 millimeter zone with terribly bad spherical aberrations, with terribly bad coma. Today, the same patient which all of us do, he gets cataract in 5 years, you can put the same multifocal as you would give a normal person.
You are not taking care of lenticular aberrations.
Lenticular aberration changes with age. Like for example, what is at 25 would change at 35, what is at 45 would change. So one good thing about what he said about the Wavelight Plus is, it takes into the account about the lens tilt, the lens accommodation, and it does a complete model of it, which is not something which we see in conventional procedures.
Maybe in future we can get the intraocular lenses also on a ray tracing type.
See, all the lenses today have some or other ray tracing principle built in it. So if you use a ray tracing laser and a ray tracing lenses and the ray tracing driven biometers, that's the way to move forward. Thank you, sir.
Thank you, sir.
Thank you, sir. Now we move on to. Yes.
Actually, epithelial hyperplasia I am covering in the next talk.